Women in low and middle income countries face higher levels of anxiety and depression during pregnancy and the first year after birth. An analysis of the maternal mental health landscape in these countries revealed around 10% of pregnant women are at high risk of suicide. The COVID-19 pandemic has only made this worse. For more, let's bring in Simone Honikman, who is an associate professor at UCT and director of the Perinatal Mental Health Project. Simone, thank you so much for your time this evening. I want to start off by finding out what are the socioeconomic and environmental factors that lead to this heightened occurrence of depression and anxiety, specifically among new mothers in low and middle income countries.
Thanks, Hanley. Women in these settings typically face several contextual risk factors related to their social environment, their economic environment. Many of these issues are gender-related, so women face a disproportionate burden in terms of caring for children, in terms of maintaining household, and often in terms of generating income and keeping families together. They also often face very, very high levels of gender-based violence, and we know these levels are particularly high in low and middle income settings. So it's really a conglomeration of these factors of poverty, of enormous responsibilities, of experiencing of different forms of violence, of having had an experience of childhood trauma, and we know that now hunger is a huge driver of the common mental disorders, depression and anxiety. The other thing is social isolation. So even when women are living or working in crowded or busy settings, quite often there is a pervasive feeling of loneliness and disconnect that many women may feel around the time of pregnancy and the time of having a small child or baby. And this marginalization or loneliness and disconnect from others for all sorts of reasons it drives these common mental health problems, depression and anxiety.
So aside from that pressure that you spoke of initially for women to not only care for children and maintain a household and in many cases generate an income, I can only imagine that depression and anxiety during pregnancy and after the birth of a child is going to have a huge impact on the ability for these women to generate an income once they return to work from maternity leave. What's the knock-on impact of that?
Exactly. So I think what we often forget is that these mental health conditions affect us in ways that affect our thinking, our planning, our ability to problem solve, our ability to draw on external resources. So when somebody has depression or anxiety, their functioning is impacted significantly. And that'll occur in all sorts of domains. So you've mentioned that it's harder to generate an income. So if it's an adolescent mom or a mother at school, it's harder if one's experiencing depression and anxiety. We know teens are at much higher risk. It's harder to complete schooling. It's harder to focus on work, to concentrate, to generate income, to do all the kind of activities that are required to be successful in academic pursuits or in income-generating pursuits. But one's functioning also is affected with respect to relationships with others, and that could be relationships with household members, relationships with the infant and children, relationships within the community. So those relationships are often come under strain when somebody has a mental health problem, or it's strained relationships that cause the mental health issues. So many of these factors exist in a vicious cycle.
So that interconnectedness also leads perhaps to other additional health issues. Either they contribute to the depression or the depression causes additional health issues that women can face. How likely are these women to seek health care?
Yeah, so the knock-on effects you mentioned, and it does relate to health-seeking behavior, are that women are more likely to experience a whole range of physical health problems, in particular obstetric health health conditions, they're more likely to have problems with adhering to health regimes or treatment regimes, whether it's taking antiretroviral treatment for HIV, whether it's attending antenatal clinics or postnatal clinic services or immunization services. They're less likely to be able to use what's available, the social services. So the knock-on effects act to perpetuate a cycle of suffering, a cycle of poverty, whether it's physical or emotional or social. It's much, much harder to parent when one has a mental health problem, whether one's a father or a mother or some other kind of a caregiver looking after a child. Anybody who's looking after a child who's suffering with a mental health condition, whatever kind of mental health condition, it's really more difficult to be responsive to a child's needs. So the impact on children has also been demonstrated.
So for that very reason, it's absolutely critical that we look at trying to resolve the socioeconomic factors and environmental factors that lead to increased depression. Now, together with some international colleagues, you've penned some recommendations. Could you take us through some of those recommendations?
Yeah, we feel that this is a kind of societal problem. It's a challenge that affects us at all levels of society, and a responsibility to address this rests at all levels of society. So, of course, we need to work on gender-based violence. We need to work on hunger. We need to work on poverty. We need to ensure that women have access to funds so that they can be liberated from coercive violent situations, and that can make their own decisions about how to spend household income. But the health system also needs to respond, and the social development system needs to respond, and community level organizations and faith-based organizations and community development organizations and NGOs need to respond, and schools need to respond. So it really does require a whole of society approach. At the top level, we're needing policy change, and we're so excited that the new maternal and neonatal health policy includes mental health front and foremost. With that needs to follow the guidelines that we're busy writing, but we also now need funds. We need a kind of fiduciary allocation of funds so that we can operate and implement interventions that are evidence-based, interventions that can be integrated as a routine, ordinary part of maternity care. There is no reason why we shouldn't make mental health care part of maternity care. We can't continue to provide physical health care. We need to look at providing care for the mother entirely. And there are all sorts of evidence-based approaches that have been tested in low-income and middle-income settings, which have been shown to be very effective. We can use non-mental health professionals, we can use nurses and midwives and general doctors and community health workers, and if we train and support them, they can integrate good practices to bring primary mental health care to women who need it. And most women who need mental health care will be those people who are experiencing mild or moderate mental health symptoms. And we would need to then be able to step up, if a woman has more severe symptoms, to more specialist care. So we need to develop these systems to prevent, to promote mental health, to detect it, and then to refer women up the system. So it requires everything from a policy level down to an operational level. We need to be able to measure what we're doing. We need to have indicators integrated into the health system, so we know how many women we're screening, we know how many women we're referring, and what's happening as a result of these referrals. We know how many health workers are being trained and capacitated and supported to provide mental health. Those systems need to be in place. We need to look at the mental health of the providers themselves, because these are the instruments of care. And we need to look after the health providers, whether they're a midwife, a nurse, a doctor, a community health worker. We need to make sure that they are looked after in their own right, so that they can provide care to mothers. And we need to look what's happening at community level, what's happening in churches, what's happening in ECD centers, early childhood development centers, what's happening in the different charities out there, what's happening on the ground. Where can we where can we bring maternal mental health into the ordinary operations, the ordinary business of what these organizations are doing. And we need to raise awareness at a public level so that everybody can start talking about this, because it's everybody's business.
Well, this is the first step, talking about it, and thank you so much for making yourself available. That was Director of the Perinatal Mental Health Project, Simone Honikman, talking about the high incidence of depression and anxiety amongst pregnant women and women who've just given birth in low and middle income countries.